All right, so we'll start off with a PowerPoint, oxygenating and monitoring the neonate. Normal oxygen levels versus hypoxemia. What is a normal PaO2 and SpO2 in the neonate breathing room air? So for the PaO2, you can put in 50 to 80 millimeters mercury or torr. So 50 to 80. And saturate, pulse ox saturation, when you have that kind of a PaO2, is 88 to 95%. So 88 to 95%. So less than 88% is considered hypoxemia. The PaO2 is less than 50, hypoxemia. And it's going to be a little different between institutions. All the way to the left. Right. Thank you for that. It's going to vary between institutions. So if you're at Broward Health, they might have the range as 90 to 95%. Then you go to Joe DiMaggio and it's 88 to 95. So there is going to be some variation. For pediatric patients, any PaO2 less than 60 torr, we want to recommend oxygen therapy. Less than 60 is going to give us a saturation of usually less than 92%. Here it says less than 90%.
So less than 92.
Yeah. I think so. I mean, I took this out of the textbook, but it doesn't make sense because when you have a PaO2 of 60, you're going to have a SAT of 92. So on a blood gas, you have a saturation of 90%. Remember, there's a little bit of a difference between the pulse ox SAT and the ABG SAT. It'll be 92 on the pulse ox, 90 on your ABG when the co-oximeter looks at it. Yes.
Professor, I think you should be writing these textbooks.
Oh, that is so sweet. I put 2 less thans, but that was a typo. So this kind of like adult patients. I saw in somebody's assessment that you turned in, I haven't graded all of them, by the way. But somebody had PaO2 was 75 on a blood gas and FiO2 was increased. I guess that differs from one patient to the next, but I'm thinking a PaO2 is 75. It's going to give you a saturation of around 95%. That's good. Why would you want to increase FiO2? I don't know if any of you does that sound familiar to anybody? No? Yeah, so why would 75 not be good enough? Like, why would you have to give them a higher percentage of oxygen if their PaO2 is 75? I was just curious. But it varies. As far as hypoxemia, how do we know when a patient has hypoxemia? Well, looking at their O2 sats, of course, but then clinically, if we see cyanosis, patient looks blue. That will occur when 5 grams of hemoglobin are not carrying oxygen. So when hemoglobin is not carrying oxygen, that's called reduced hemoglobin versus oxidized when the oxygen is on the hemoglobin. So if there's 5 grams without oxygen, the person's going to look cyanotic. That'll occur with a 75% saturation from newborns that still have their fetal hemoglobin. Their PaO2 will be down to 30 millimeters mercury when you're seeing cyanosis. So a lot lower than in adults. And the reason is because of that fetal hemoglobin having a stronger affinity for oxygen. Another word you come across is acrocyanosis. Acrocyanosis only indicates that you have poor perfusion. So there's less blood flow to the extremities. So the fingers and the toes will appear cyanotic, but that doesn't mean that the oxygen saturation is low. It just means that there's poor perfusion to the periphery. So the mucosa will still be pink. So when you're looking at the lips and inside at the oral mucosa, it'll appear pink, but the extremities will be blue. So good O2 saturation, just poor perfusion to the extremities. It's called acrocyanosis. So in looking for hypoxemia, it's better if you look at the lips, the tongue, and the mucous membranes to see if you have that pinkish color. I had to go back because I have a note written down and I didn't put it down. Looking at hypoxemia in neonates. So when they're premature, our goal is that lower oxygen saturation. So keeping them around 88% is just fine. Full term, your 38, 40 week gestation. Now you're looking at that higher number. So a PaO2 of 80, saturation 95%. And then the exception to the rule is when a baby has PPHN, we know that hypoxia, acidosis is going to constrict the vessels even more. So how do we prevent the hypoxia? We use higher levels of oxygen. So with babies that, and again, they're going to be usually full term, 38 to 40 weeks. So it's okay to use extra oxygen. Extra oxygen will dilate the pulmonary vessels. So I wrote, if neonate has PPHN, keep PaO2 greater than 100 to help dilate pulmonary vessels. So I'll write that in the chat. So if neonate has PPHN, keep PaO2 greater than 100 torr to help dilate pulmonary vessels.
And that can be used along with the nitric oxide, right? To increase oxygen, or do they usually do one or the other?
Usually one or the other.
I'm confused, like how long are they keeping, like, you're keeping a high FiO2 for it usually?
Maybe, but not necessarily.
Because I thought they don't want to do that for like the free radicals and stuff. I thought that's why they use the nitric.
Yes, so it's true. So to treat PPHN, if you give nitric oxide, that's going to dilate the pulmonary vessels. But also to let you know that the PaO2 does affect pulmonary vascular resistance. If they're hypoxic, their vessels are going to constrict. So to keep the PaO2 greater than 100 in those PPHN babies is good. And it's not gonna hurt their eyes because their vessels are already formed. Remember, PPHN happens with your term babies, not your preemies. Yeah, as far as free radicals, and giving increased amounts of FiO2 does increase free radicals. And that's why we always avoid high FiO2s unless we absolutely need them. But we wouldn't just, oh, we want to make sure the baby's oxygenated. Let's put them on 70% FiO2. And in the back of our mind, we know that's not correct thinking. We want to use minimal amounts of oxygen to keep the sats where we want them. Typically, hypoxemia goes along with some respiratory distress in neonates. And then how do you know that they're in respiratory distress? And then, yeah, it lists the things that you're going to see. Tachycardia, tachypnea, nasal flaring, intercostal retractions, expiratory grunting, paradoxical chest movement. So probably have low lung compliance leading to all of this. So it's like one big package with low lung compliance, hypoxemia, and respiratory distress. When a neonate has severe hypoxemia, their response to hypoxemia is the heart rate drops, and then they go apneic. During report, the neonatal therapist told you the baby had 10 episodes of A, B's, and D's during the shift. What does that mean? Very good. Apneas, bradycardia, and desaturation. So 10 episodes. Okay, and then for oxygen therapy, it goes without saying that we monitor all neonates with a pulse ox. And then especially in premature neonates, we're always monitoring SATs because we want to prevent too much oxygenation affecting the eyes. All right, so what types of oxygen devices are used? The oxyhood is used, I think, still at Broward Health. Joe DiMaggio doesn't use it. At Broward Health? Oh, you're at Joe D. At Broward? Okay, so they're still using it. So with mild hypoxemia, then they'll use an oxyhood. Although it can provide FiO2s up to 100%, we don't really want to put them on 100% via oxyhood. All right, so the setup for the oxyhood is your flow meter will be attached to a blender. Why do we use a blender instead of just directly from the flow meter? Do you know? I didn't hear you. The right amount of oxygen? Couldn't we do that by attaching to the flow meter and just adjusting the flow?
So they can get pure oxygen, we need it mixed with air to be pure oxygen.
Okay, so we can control the FiO2 on the blender and still give adequate flow. So it's not like we have to reduce the flow so we don't give too much oxygen. We could give a lot of flow at a specific percentage of oxygen. Having air flowing into the oxyhood, you have to have at least 10 liters per minute flowing in so that you're washing out any CO2 and they don't start rebreathing their CO2. There's different ways of heating up the air flowing into the oxyhood. So you can use the Fisher and Paykel setup, the heated humidifier. That'll warm up the air to body temperature and then blow it into the hood. You could use a heated aerosol. You want to make sure that it's warm though, like up to 35 degrees Celsius before it enters the hood. One of the disadvantages of using an aerosol, and I don't think anybody's using it. Well, just in case it's a test question on your national exam, it's better to have the Fisher and Paykel set up for your heated humidifier with the oxy hood. Using an aerosol, that air entrainment port, entraining air, it makes a lot of noise. And that noise, it resonates inside the oxy hood and it causes noise, increased noise levels and increased stress to the newborn when you're using an aerosol. So if they're not using the Fisher and Paykel and they're using the heated aerosol, it's going to make a lot of noise, and that's one of the disadvantages. No, it is not. So if you have to pick an oxygen device, so a baby has hypoxemia, which of the following oxygen devices would you recommend? And if they're older than 3 months, they don't hold still. So you can't put an oxy hood on them because they're able to turn their bodies around. And so that's why it says 0 to 3 or newborn to 3 months is the indications for giving oxygen therapy to a newborn. If you have to analyze the FiO2 you're delivering, you analyze inside the hood. Not outside or not in line, like you don't put the analyzer and the tubing outside of the hood, you have to put it on the inside. So what would happen? Here's a good question for using your critical thinking. You're delivering 30% flow or 30% FiO2 to the oxy hood. You put the oxygen analyzer inside the hood and it's measuring 25%. What could you do to correct the problem? If you're thinking, well, increase FiO2, that's the wrong answer.
Increase the flow.
Yes, very good. Why does increasing flow make a difference?
Want to flush out the
Very good, yes. So room air is coming into the hood and you need more flow. So that's why fixing that problem would require increasing the amount of flow going into the hood. You can use a nasal cannula. There's pediatric flow meters that you'll see in NICU and PICU where they go up to like 2 liters a minute and that's it, or they'll go up to 5 liters per minute and that's it. So the most you can get is like 0 to 5 liters. And then there's of course bigger increments. So if you want to give 1/4 of a liter per minute, like 0.25 liter per minute via nasal cannula, you could do that. Here it says 1 liter per minute of flow provides about 60% FiO2 or 0.6. I shouldn't put it like that. I should put 0.6 FiO2. Why not FiO2 of 0.24 as on an adult? So we put a 1 liter nasal cannula on an adult and we estimate the percentage of oxygen they're getting in their lungs is about 24%. Yet we're putting pure oxygen through the nasal cannula. So what are they breathing, or what are they doing to?
They can only really breathe out of their nose. So if you have a cannula, then they're like adults can have their mouth open and not still.
Yeah, you're almost there. Yes.
Could it be because their nose is smaller?
What else? How do we go from pure oxygen coming into the cannula to 24%? on an adult. You do the adult first.
Is it because they can, adults can train them in the environment, right? And can still breathe environment, so they're not breathing in it.
So the first part was correct. It has to do with air entrainment. So an adult, to get their tidal volume of 400 ml, you get so many mLs from the oxygen flow meter, and the rest of it you're in training room air. So with neonates, you can have a cannula in, and if you have the right size nasal cannula in a neonate, they're going to be able to inhale and exhale around the prongs. If the prongs are really big, no, that's not good. Now you're thinking of nasal CPAP. But with a nasal cannula, there should be room around their nasal prongs, and they should be able to entrain room air. But the tidal volume of a neonate is tiny. Maybe like preemies, 5 ml tidal volume, 12 ml tidal volume. So let's say on a full term, 20 ml tidal volume. So that 1 liter per minute flowing in, that's most of their tidal volume. And very little air has to be entrained when they're breathing in. So it has to do with air dilution. An adult breathes in a lot more air with the flow. Neonates breathe in very little air with the flow from the nasal cannula. Should I put that in the chat? Yes. So I wrote, an adult breathes in a lot of room air along with the flow from the nasal cannula. This dilutes the amount of FiO2. A neonate has a much smaller tidal volume and doesn't entrain as much room air in addition to the flow from the nasal cannula.
When you say in addition, do you mean like because of the flow from the nasal cannula? Or
So if you put a nasal cannula on a neonate and you set the flow to 1 liter per minute, that 1 liter per minute of flow from the nasal cannula is pretty much all of their tidal volume. They breathe in a little additional room air around it, but 1 liter per minute, you're pretty much supplying them with all of their tidal volume.
so the reason they're getting in training less air is because of the flow? Or am I making a connection?
The reason they're entraining less air is because their tidal volume is small and the cannula is providing most of their tidal volume. Did that help?
Yeah.
And then having a nasal cannula on them Instead of just having a pediatric flow meter and giving like a 1/4 liter per minute, you could have put it on a blender, give them 2 liters a minute of humidified air, and adjust the FiO2 on the blender. So you always keep the flow at 2 liters a minute, but then you adjust the FiO2 on the blender to make sure their sats are in normal range.
I promise moments ago, but I did not understand. this. Now
Oh.
I understand.
Tell me what you understand.
So blenders, so neonates don't entrain room air like regular adults do. So blenders are more, how do I put it? It's more like preventative of over oxygenation in a way, right? For neonates. Because
Preventing,
right, this is just my thought process.
Okay.
Because it says 1 liters per minute provides 60% of FiO2. That's on a neonate because they don't entrain room air like we do. So on a regular flow meter, my question is on a regular flow meter. So if we didn't put it at 1, if we put it at like 0.25, then would it give them 24%? Okay,
yeah,
it's just a little different.
yes. Yeah, so with a blender, you've got 2 things to control. You've got the flow and you have the FiO2. If you want to keep the flow going, you can just turn your FiO2 down.
So it can provide flow without oxygen. Or with a lower FiO2.
With a lower FiO2, yes. Provide flow with a lower FiO2. Very good. So with the blender, you can provide flow without a high FiO2. And then I also have infants are obligate nose breathers. Have I explained what the word obligate means?
Yes.
The tongue is so big that they're obligated to breathe through their nose. The extra flow to the nares creates a positive pressure on exhalation. So that's a little extra bonus, right? Having to exhale against this air coming into your nose. It creates a little bit of positive pressure in your airways. And we know that that helps improve oxygenation. Should I write that down?
Doesn't even have to be a high flow nasal cannula, it can just be a nasal cannula.
Yeah. Okay, we'll keep going. Next for improving oxygenation in the neonates is CPAP. How does it help? It says that it increases mean airway pressure. And this is going to help in a couple ways. It reduces ventilation perfusion mismatch. So having that positive pressure in the alveoli stay open. And now the pulmonary capillary blood flow from that alveoli is going to be able to pick up oxygen. So reduces ventilation perfusion mismatch. It prevents terminal airway closure. So having lungs that are stiff, atelectatic, if you have some positive pressure, it's going to keep those little tiny airways open. So the terminal airways will stay open. Third, it recruits collapsed alveoli. So when do you recommend that a infant be placed on CPAP? So if they have hypoxemia, you can recommend nasal CPAP. If they have RDS, nasal CPAP helps. If they're experiencing respiratory distress, nasal CPAP helps. After extubation, they typically go on to nasal CPAP. So you wean them from the ventilator, you extubate them, you place them on nasal CPAP. And using nasal CPAP also helps apnea of prematurity because of those flows into the nasopharynx are a stimulant. Which of the following do you think would be indications for CPAP? First one, RDS. Yes. What about congenital diaphragmatic hernia?
No.
All of that positive pressure going into the stomach, not a good idea, right? What about respiratory support after extubation? Yes. Would it help airway closure disease such as tracheomalacia? Yeah. Yeah, and the positive pressure keeps the trachea open. Apnea and bradycardia of prematurity? Yes. What about choanal atresia?
No, they need mechanical ventilation.
Yeah, they need an airway.
Yeah,
Surgery to open up the way.
They need surgery. Yeah, so to place an airway until they can have surgery, yes, but not nasal CPAP. It's not going to go anywhere. What about a pneumothorax? Is nasal CPAP a good idea for a pneumothorax?
No.
No. Positive pressure, it's going to cause the pneumothorax to get worse. Good job. There's different ways to deliver nasal CPAP. You can use the ventilator. So the servos have a way of putting the babies on nasal CPAP, and you can just keep the ventilator there. And that way you can monitor the pressures. It keeps track of, I don't know if the servo I keeps track of respiratory rate. I think it does. It does. The second way is bubble CPAP. You're going to be setting up a bubble CPAP today. So hopefully lab gets started on time. Today in lab, you have 3 stations, but it's possible to get through all 3 stations in one day. So you'll be setting up high flow via the vapotherm, high flow via bubble CPAP, and then high flow for an adult. So you get some hands-on with that. This picture is showing a circuit with nasal prongs. So this is nasal CPAP. If the infant has mild to moderate respiratory distress on room air, that's an indication for nasal CPAP. What if they had severe respiratory distress? Say it louder. Yes, very good. When you're setting up nasal CPAP, neonates need a flow of 5 to 6 liters per minute, and then the bigger babies probably a little bit more, up to 10 liters per minute. So when they are exhaling against these prongs that are blowing air into their nose, exhaling against that flow creates positive pressure. And when you place an infant on nasal CPAP, typically it's between 4 and 6 centimeters of water. You can go up to 8 centimeters of water if their O2 sats are not improving, but any higher than that, they're not able to exhale. You know, if you're shoving all this flow up their nose, when they try to exhale, they can't. So their CO2s end up climbing higher and higher and higher because they just can't exhale against those higher pressures. And that's the reason why you don't go above 8 of CPAP when delivering nasal CPAP. Does that need to go in the chat or you're good with it?
Okay.
Got it in my notes.
Brent? Good, okay. You're welcome. Bubble CPAP is, it's a really cool setup, like the expiratory tubing goes into a container of water. And when air is placed inside of water, of course, the bubbles form and then the bubbles have to rise to the top. So it creates this bubbling action. And the bubbling actually creates oscillations in the circuit. And when you set it up later, if you just touch the circuit, you can feel the oscillations. So the oscillations are supposed to also help. That's the claim, that it improves work of breathing and oxygenation. Don't know how they figured that out, but again, we know that the positive pressure improves oxygenation, and then the oscillations, I guess, are just another plus. Oh, and this is showing the setup that I just described. So you've got your blender set up, you've got the flow from the flow meter coming into the humidifier chamber. You'll have to put a pressure pop-off device on there. So for some reason, pressures inside the circuit go higher than 17 centimeters of water. The excess pressure will go out this little, it looks complicated when you look at it, but it's just for a pressure pop-off. So the flow goes through, picks up warmth and humidity from the humidifier. And then it's delivered to the nasal prongs. When the baby exhales, the air flows. It's the white tubing. It flows into this container that has water in it. And it's the air going through different levels of water that create the positive pressure. And the bubbles create the oscillation. So bubble CPAP. Who's in neonatal ICU? Corinja, have you seen this yet? Okay, good. And Rachel, have you seen it? Yeah. A high flow nasal cannula is different than nasal CPAP because the amount of positive pressure is minimal and it cannot be measured. So both of those are the main points for delivering high flow cannula. You can't call a high flow nasal cannula a nasal CPAP. And the reason you can't is you can't measure the pressure. And the amount of positive pressure that you get, it's limited to 3, maybe up to 5 centimeters of water. So with a high flow nasal cannula, gas is heated to body temperature to improve the comfort of the high flows entering the nose. Positive pressure is created by the high flows via the nasal cannula. So if you blow enough flow into the nasopharynx, it's going to create a positive pressure. That positive pressure gets felt all the way down to the alveoli. So it says it improves FRC. Do you know what that means? How do you improve FRC? It's functional residual capacity. Very good. So having alveoli open, having your airway stented open, now you're going to have improved FRC versus everything being collapsed, and FRC would be lower than normal. We also know with a high flow cannula that the high flows wash out the exhaled CO2 in the anatomic dead space. So here's one high flow nasal cannula. The company is called Vapotherm. On the front screen of the Vapotherm, you see the flow delivered to the nasal prongs. You see the FiO2 being delivered, and you see the temperature of the airflow. So you get to play with it now, but if you're going to be working in neonatal ICU and you want to be able to set it up really quick and understand everything, the Vapotherm website has tutorials for you to go through. So it's a really good resource. For the next few slides, identify the type of device. So this is our choice. We have to pick high flow nasal cannula, nasal CPAP via nasal prongs, or nasal CPAP with a mask. So the way we're going to know high flow nasal cannula is that the prongs are not going to completely fill the nares. So with a high flow nasal cannula, there's room around the nares. Nasal prongs, you're going to see that the prongs completely cover the nose. Nasal CPAP with a mask, they make these teeny tiny little masks that can go over the nares. And I know Broward Health does this, like they'll switch off, and because when the nasal prongs are resting on the skin, they can irritate the skin and create breakdown of the skin. Even though they're made out of silicone, they're super soft, and still just sitting there, you know, hour after day, skin breakdown occurs. So what they'll do is switch it over to a little nasal mask, maybe for a day, and then they'll switch it back to the nasal prongs, just so that there's different pressure points, I guess. All right, so what do you think about this first picture? Very good. So this is nasal CPAP, and this bar that they use,
Looks like it's got a mask.
does it?
The mask is going over his nose.
Maybe you see the light shining right here.
Yeah.
And that's why you think that. But there's some prongs coming out of this bar and going into this nose, and then another prong coming into this nose. So that's nasal CPAP via nasal prongs. And what about the picture on the bottom? Yeah, high flow nasal cannula, and you can tell because there's room around the prongs. Well, here's our students posing. Have you guys seen these guys working? I think they all ended up working at Broward Health.
Have not seen them.
No,
They were-
Kelly.
They had a mask and strong.
Wait. Maybe her. What's her name?
Kelly Rodriguez, Vanessa Swan,
Vanessa.
and Mark Alphonse.
Yeah, I know Vanessa.
Oh, okay.
Wait, what was that? I'm sorry. The one before, that was the.
The picture on the bottom.
No,
No,
the
you
slide.
didn't tell us what it was.
Oh. Yeah, they keep changing the interfaces that they use for putting nasal CPAP on the babies. And I kind of gave up. Like, I still have the babies in the back of the room, but I teach you guys one setup. The next year they change it, then they change it again. And I just kind of got tired of trying to keep up with the different interfaces. So you don't have to put the straps on to hold the prongs in place. But you will be taught that when you're doing your neonatal rotation.
That's the CPAP with nasal.
Yes. Looks like some of these are repeating themselves. There's a name to this bar that they use at Joe DiMaggio, and I can't remember the name of the bar. Can you tell by the circuit, though, that you're delivering positive pressure? All right, so that's nasal CPAP via nasal prongs. And here you can't see the mask, but there's a mask covering the nose. So that middle picture will be nasal CPAP with a mask. And just looking at the circuit at the bottom, you don't see any tubing going to the setup. Is that one clue? That you're not looking at nasal CPAP and you're looking at high flow cannula? And then this one, you can see the mask a little bit better. How it's covering the entire nose. So that's nasal CPAP with the mask. And what's this one at the top? So there's no tubing other than this thin tubing. And then you've got a towel wrapped around the neck. I guess you see the towel on both sides. So don't think that that's a circuit. All you have is this green tubing.
So just high flow.
Very good. So that's high flow nasal cannula. All right, it's 10 to 11. Do you want to take a 10-minute break? And then we'll keep going? Okay,
What time are they coming today?
11:30. All right, before I turn the lights off, I have some wet gases written on the board, and I'd like you to recommend therapy. So newborn is on room air, has a pH 7.32, PCO2 is 45, PaO2 is 45. What do you recommend?
Nasal cannula.
Okay, nasal cannula?
Yeah.
And how much oxygen do you want, or how much flow do you want?
1 liters per minute.
1 liter per minute? Okay. Any other suggestions?
That's if I. The lower than that?
Mhm.
Yeah.
Okay, so nasal cannula,
Maybe 20.
yeah, 0.5 liters per minute, 0.25 liters per minute, yes. Okay. It would put that newborn in an oxygen and deliver some extra oxygen via the oxygen.
Yeah, that would work.
And we see a little bit of acidosis, but do we need to intubate and ventilate for that kind of an acidosis?
No.
Could we put them on nasal CPAP?
Yeah.
Yeah, pretty much nasal CPAP is always the right answer. So that would be another choice.
Which one is the best?
Nasal CPAP is typically what we use. And like these choice, well, you still have to have the plastic on the face with a nasal cannula. Oxyhood, nothing touches their face.
Loud, right?
It could be loud if you use an aerosol to warm up the air, yeah. Yeah. This should make out with a oxygen, yes.
So do we always have to have a normal CO2, because I know at the NICU at GOG, they like permissive hypercapnia all the time, so that's why I'm looking.
Yeah. So, yeah, 45 at Jody is more than 5. Like they tolerate like a CO2 of 70, don't they?
Like, I think 60 is what they go to max. I have it written down.
Yeah, it changes with the type of baby. If the baby's chronic, they tolerate like really, really high CO2s in some ages
Yeah, so they don't, it's like, I think volume.
to prevent volume trauma, or to just tolerate the high CO2.
Yeah. Or what if they have, you know, a little bit of a walking. Maybe cheese.
Yeah, so one thing that helps when you're getting your review during the Kettering seminar, they tell you the normal values that NBRC
That's
looks
what
for
I'm
when you're
trying to
taking
figure
your
out here,
test.
because I'm confused.
Because it's kind of hard with, just two hospitals so close to us, and they do things so different.
Yeah.
So what Joe DiMaggio would do, Broward Health would not do. So it's kind of hard to come to a consensus. And then what does NBRC want you to do? So one thing that NBRC does want to see is if you're safe and you recognize that the baby's not breathing well enough and they need to be ventilated. So do you see any ABGs on this board where you would say, you know what? That's pretty acidotic. I think we need to intubate and ventilate.
That's
No, that's not-
Yeah. And then what about being on an oxy hood and still being hypoxemic?
It probably be better kind of like an oxygen. It's probably not doing it for him.
Right,
Like follow the pressure.
very good. So what would give positive pressure? Yes, nasal. All right. Got like 15 minutes. Did I skip one? When drawing a blood gas from a neonate, I find it impossible, but the respiratory therapists working in the neonatal ICU are so good at it. Capillary blood gases are easier because then you just warm up the site, stick, and blood comes out.
There's the cord for it too.
Yeah, so drawing blood from the umbilical artery. Yeah, that's a possibility also.
At Joji, most of the babies have A lines. The nurse actually pulls from the A line for the RT.
Yes, very good.
So when they cut the cord, how long after can they still use that, like, draw blood, how long do they stay on it?
I think it's up to 24 hours after delivery. They're still able to cannulate it. And then after that period of time, the blood is no longer flowing.
That's it, how long?
Yeah. Is it a? When I.
Yes.
This is just a random question, because I just want to know for curiosity's sake. The other C-section I saw on Friday, they had the baby and like, after they cut the cord, they were like pushing all the extra blood in the cord down into the baby. Like, is that okay to do? What's the whole purpose? Just to give them the extra blood, or?
Yeah, to make sure they have good blood volume. Yeah, too much blood volume can lead to some pulmonary edema. But the practice is, make sure they have good blood volume, good blood pressure, and that's why they do it.
Well, seeing some exciting stuff.
Yeah.
Yeah. It was fine.
Oh, up to 48 hours after birth. Sorry, I said 24. So if you're going to draw arterial blood, one place you can draw it is from the right radial artery. Matter of fact, when they're looking for preductal, postductal PaO2s, they're going to ask you to get a radial, draw a blood gas from the right radial artery. And those arteries are so tiny. Do you know what size gauge needle to use? So if you're using a 23 gauge to stick an adult, what would you use to stick a neonate?
Does it go smaller as it goes up?
Yeah.
Oh, like 30.
Yeah, so like 25, 26 gauge. It's like the size of a TB needle. It's really tiny.
So are we supposed to be seeing a PowerPoint?
Yeah. Thank you, Corinja. So usually they use ultrasound if they're having a hard time finding or feeling for the pulse and sticking the vessel. So ABG sites, right radial artery, and then the other one is the umbilical artery. So in birth, up to 48 hours after birth, the umbilical artery can be cannulated.
What about the umbilical vein? I'm just curious.
Yeah, and then the picture is, I guess, what before the baby is born. So after the baby is born, where you see blue is actually going to be your oxygenated blood,
Mhm.
not the umbilical vein.
Right, because the umbilical vein is just, could be used to deliver medication.
Yes.
Because the baby I had, she was 2 days old, and that's what they were using the umbilical vein for. They couldn't use her arteries. It was just a UV, I think it's UVL. Umbilical, yeah. Okay,
Does that mean they keep like a segment of their little cord, or is it just like literally the little belly button that's left on them that they're doing this on?
The little belly button that's left on them. And then I just want to clarify this. It says the umbilical artery is used for monitoring blood pressure, makes sense, and administering fluids and blood products. You don't administer fluids and blood products to an artery. You administer fluids and blood products to a vein because you want it to go back to the liver and then into general circulation. So I just wanted to clarify that. In order to keep the line patent and prevent any blood clots from forming, there's heparin continuously being infused into the line. And placement of the catheter may interfere with perfusion. So when the catheter is placed, an abdominal X-ray has to be obtained to make sure that the catheter wasn't pushed up too high. Because if it was, it interferes with perfusion to the kidneys because on the descending aorta, where the blood flow to the kidneys branch off, it's close to the umbilical artery and vein, and it could interfere with perfusion. And then it says occluded blood flow may lead to loss of limbs. That's not good. So I'm showing you a normal capillary blood gas values. And it looks like the acidotic side of a normal blood gas for an adult, as far as the pH, the PCO2. So our normal range is 735 to 745. 735 we say is on the acidotic side. So that's a good way to remember. A normal pH for a capillary blood gas is 7.35. Like the acidotic side of normal is normal for a capillary blood gas. CO2 45, that's the acidotic side of normal for CO2 in the adult. So that's how I remember a normal pH 735 and normal CO2 is 45. And again, what's normal is going to vary according to, oh, it has it at the bottom. I'll tell you about O2 in a second. So newborns, as long as the pH is greater than 7.2, CO2 less than 60, they're happy and they don't make any changes. Because we would look at this and say, hey, I think we need to be intubated. Babies that are chronic, so they've got BPD, they'll tolerate a pH of 7.25 and a CO2 of 80, rather than trying to ventilate them more to get those values down to normal. So this is what you're going to be seeing in the NICU. When you're asked on the next exam, when is your next exam? 2 weeks from today?
The 17.
Okay, so in 2 weeks, you have to put down normal values for a capillary blood gas. Put down these values. 735 pH, 45 CO2, and then for O2. 40 to 49 is an acceptable PaO2. I can't say PaO2 because it's capillary. Can I say PCO2? Or how about just PaO2? I'll say PO2. PO2 for capillary blood gas, 40 to 49. And remember, you've got a mixture of arterial and venous blood when you're drawing capillary blood. That's why your oxygen level is a little bit lower than arterial. But the reason for a capillary blood gas is not to look at O2 sat because they'll use the pulse oximeter for that. The reason for getting a capillary blood gas is to look at the pH and the PCO2. Is there anything else I wanted you to tell? Typically, a capillary PO2 runs about 10 torr less than arterial PO2. So if you come up with a PO2 of 49 on your capillary blood gas, add 10 to that number, and that's what you most likely will see with your arterial oxygen level. So 59 would be like what the PaO2 is. And I think we need to stop. A couple more things to tell you. So if you were told to draw a brachial ABG on a neonate, would you do it? No, it's too deep. If you were told to draw a femoral ABG on a neonate, would you do it? No, too deep. And then also neither one has collateral circulation. So if there's any damage to the vessel, there's no blood flow going to the periphery. And the vessels are not close enough to the surface of the skin. I must have come across that in like a test question somewhere. When you're using an A line, do you have to waste the first few mLs of blood that you pull from the A line? Very good. Okay. Before sticking the neonate, is there anything you can do to lessen the pain? Lidocaine. Could you use an anesthetic cream on the wrist? And what about a sucrose pacifier?
Like a sugar cube.
So a sucrose pacifier, they suck on it and the glucose, I guess, tastes so good, they don't notice the pain when you stick right with it. When you stick their hand. Yes, distracting them with something pleasurable. So supposedly in the brain, when you have a lot of pleasure, response in that impulse is going back, afferent, I guess, afferent impulse is going back to the brain. It blocks the pain impulses that are being perceived. So yeah, talk to the moms after they've given birth and ask them, did you feel the pain, or were you just so excited that the baby was being born you didn't notice?
Oh, no.
You're not gonna ask them that.
I don't know. My friend said she didn't even really remember.
Oh,
to be
really?
honest.
Oh, that's a good thing. Did they give her some narcotics?
No, it's no drugs. It was just that traumatic. And she just wanted him out. So she didn't really remember. All she knows is he came out. And that was it.
Your input is
So
I remember the pain like leading up to it, like all the contractions and stuff, but like the actual birth,
Interesting. So yeah, that's pretty cool.
How do you not remember the worst pain?
I think it's that traumatic.
Because you black
out. It's traumatic.
your
Yeah.
body. Can
They
you
go
notice it?
No. But then again, that was, well, C-sections for both babies, but I had labor for the first one. And I don't remember. I think at the time they were giving Demerol for pain.
I was like a crazy person. I was like yelling at them.
Oh, really?
Because I was trying to do it without an epidural. So I said, no, no, no. And then it got to the point where like it was hurting so bad. I was like call the doctor, I want the epidural, and they're like, you waited too long, you can't get it, and I was like, that's BS, like, you better give it to me. And they were like, well, you're so close now, if we give you the epidural, it's gonna like delay the birth process, because you won't feel the pain and you won't know to push, and I said, I don't care how long it takes, if I can't feel the pain, that's fine. And I got them to give it to me.
You
and-
did?
yeah, and I was in labor, I went into labor at like, I think it was around like 8 or 9 p.m. and I didn't have them until 12:03 a.m. the next day, so like.
Oh, my gosh. By then the epidural wears off, doesn't
Well, I
it?
didn't get it till like the very end,
Oh, I see, I see.
so, yeah, I don't remember any pain like during the actual birth, just all the contractions leading to it.
Yeah, it's a long
And
time
the
to be
water
in
never
pain.
broke, they had to break the water for me.
Is that when it just stick there?
I don't remember how they did it, I just remember them saying like.
You get
"These water
violated as a
cells-"
female when you're having a baby now.
Oh, yeah.
You don't even care no more
I walked
after
through
a
the room
while.
last week with the C-section, that lady was just full naked on, I was just like, okay, I mean. Just kidding. Respect this lady's privacy a little bit, you know, and they just, as soon as they put everything over her, it was better, because they have this thing and drapes over all of her, and then it also has that tarp that goes up as part of it. So. But walking in there like that, I'm just like, this lady's brave, because I'd be like, y'all need to cover me up right now, I feel exposed.
I'll never forget, I walked past a C-section in the OR, just to, I was trying to put something in the Pyxis and I couldn't go in because they were doing the C-section and all I saw was blood and a baby.
The second one I saw. was
And
not-
the lady on the other side, you know, she's drugged, she can't feel anything, she's just staring. I'm like, I'm good. I don't know about any
The
of
lady I
this.
saw was so calm, I was like, how?
Oh, no kidding.
But what is really better,
Inspiring.
to push the baby or the C-section? Which one is better, like? And it's term of traumatic.
It's all bad, Wisdom.
It's all.
It's all bad.
So yeah, to give a non-subjective response, I don't know if I could. I know C-sections are safer, where things don't go wrong like they can with a normal delivery. So that's one of the good things. But then you're being cut open, so now you have to heal from the surgery on top of caring for a newborn. So good and bad.
Do we get cut open or do we get ripped open? I don't know. None
No,
of
they get
this.
cut open. It's
None
not
of
really
this
cut.
sounds.
There was some reputable ones I saw,
Oh.
like those two doctors were like.
With the
I
clamps,
was like,
none clamps.
I could
Oh my
not believe. It was the most shocking thing, the second most shocking thing I've ever seen.
The second one I saw,
Wow.
They were pulling that woman apart.
yeah, the first one was like that for me, but the second one was really
Wow.
smooth. The only thing was when they tried to get the baby out, I think because it was so slippery, his head just was like not coming out. They had to, like fight with like the uterus and stuff just to like pull his
They
head
had to
out.
they tore, it was like,
Oh my.
they had to make it room. And they made, like, the first is
that a big baby?
going in nice and neat. They got the scalpel, they get through all the top layers, and then once they got in there. Once they had kind of access to get their hands in there, they were just like, I couldn't believe it.
Is it?
You think the husband can be in there while?
He is,
Yeah.
he is.
Oh, he can be in there?
Yeah.
He's sitting right next to his wife. He doesn't see it unless he
I
wants
think
to, I guess.
I think that there wasn't any family members in there with the women that I saw that gave birth. And there's a sheet, you know, she can't see what's going on, but I'm sure she could have heard it.
She can feel it from what I mean.
Yeah.
It was violent.
Do you think maybe like, it depends on how much adipose tissue a person has? Because if you're thin, they just open it and it's right there, where like, if there's a lot of
Yeah,
adipose, I would think there's like.
The
more
first
to-
lady I saw, like, they use these metal hooks to like hold up the skin, but if you have the fat, you can see the fat
The
too,
fat.
so you just see it like being pulled up with like a giant metal, not like a hook, but like a. Someone holds it up and then like the doctor has to keep cutting it, so yeah, I definitely think.
Can they check out the fat at the same time?
You're
don't know.
not getting lipo while you're getting
Yeah.
baby, you know?
I always think the same thing. It's like, while you're there, could you like remove a few inches for me?
That's the thing, when they do like the mommy makeover, like, while you're already open.
Really?
Yeah,
What?
Interesting.
yeah.
Oh,
That's
no
kind of
kidding.
cool,
Yeah.
actually.
They do like a tummy tuck when they send you back up.
Like they always do it, or you have to ask
No,
for it?
like you can ask, you can request it. I had a friend who did that.
That's really cool.
Okay, so it's modern day.
But isn't it more risky than?
I mean, they're cutting you open anyway,
This is
there's the
all
risk
bad.
itself.
It's been, like I said, yeah.
Bad. Yeah, I mean, you just exercise.
I do like how the tongs that they use to like cut, the scissors they use, like they're made so you can solder the vessels closed on it, you just hit it with the soldering and it just like fries the vessels closed.
Prior to the cut.
No, after they cut them, like, cause sometimes they have to cut through an artery or something, and then they clamp it, it's like clamped with the scissors, and then they just use like a soldering thing, they just tap on the edge of them, and you just see like smoke come up, it's like burning. I didn't see that, so.
I used to go and use the phone drive. That's how they. That opposed to shoot everything, they had like a soldering gun or something.
Yeah, the soldering gun.
After they got through the skin, when they're inside the body, they use the soldering gun, they go down this thing. It was wild.
Yeah.
So is this class called birth control 101 or something?
I remember saying, I was like, you know what, they should have video of this, they should, like, they need to get a video of
High
the childbirth.
schoolers.
So that they have it. So when those kids start talking back and acting up when they get a little older, you know, they'd be like, you know what, come here, sit down, I'm gonna make you watch something, this is what I went through to bring your ass into this world, you know?
Played in our sex ed class at my high school, that same video you played for us, they should have just played that
Yeah.
for everybody to see.
They showed something to me like in 8th grade, and I'm pretty sure there were still kids getting knocked up.
I don't think they get it. I think that's why the husband should be there too. Like, you gotta
If
make
they
them,
have a
and-
husband.
Yeah. You gotta make them sit there and see it.
Yeah, that's true.
Mhm.
Yeah,
For the
for
respect.
more reasons than that. I wonder if that's somebody's putting them on.
Also, it's really awkward because you're standing there and like the dad's there and like. I'd look over just to like look at everything and I always end up like catching eye with the dad and just like,
Isn't fair, like what's his name?
I don't know, just look and I just give him a quick back. Like,
I had an uncle that passed out from watching the C-section of his life. She just passed out.
it's gory, bro. The second one was not the doctor, and the second one was really good though, because they were fast and they were efficient, like they didn't make a mess. The other one I saw was gross. And there was like a chunk of something.
Yeah, that's such.
I feel like if you're having that kind of.
Oh, you know what happened with the second one? You had a fibroid or a hematoma or something. For not 900 units. We're gonna have to get that out too. I like how it's. Vaughn, you want to stop your recording?
I need to stop recording, right? All right. What I wanted to tell you guys while the recording was still going is, next week we're meeting at Joe DiMaggio, I think at 9 o'clock. So I need to send you an email to update you. So we're reversing everything next week. We'll do lab in the morning, and then after we go home, I'll finish up on this lecture. I know you have an exam coming up in 2 weeks.
Are we parking in the parking area? Or can we park at the hospital?
Wait, we're doing lab.
Oh,
So in order to park in visitor parking, just wear regular clothes, right?
oh, but I'm saying we can show up in regular clothes. for it?
No, not to go, because we're just going to the respiratory department, and either they're gonna set us up there or they have a room for us.
Okay.
But you're gonna need your badge to get in, so. I think 9 o'clock, so I need to send you an email as a reminder to the time for next week.
So you said it's reversed, as in like we're online after the one year, or like here?
Yes, so instead of having lecture next week at 8:30, we're not gonna have lecture next week at 8:30. Instead, you're gonna drive to Memorial Regional and meet in the respiratory department. I think it's at 9 o'clock. That's gonna be your lab next. week, Is working
Oh.
with the Bella Vista. Then we finish, I'm thinking, what, like 2 hours to work with the vent, and then we leave and go home. And I will give you the rest of this lecture online via Zoom.
Oh, that's great. And we'll figure out time after we've done the lab and everything. Like we'll figure out what time and everything after when we get out and stuff.
Yes.
Works. I can